It's Graham Paget. I'm the head of the renal division at Johannesburg Hospital, and welcome to the Friday morning meeting. Last year, the Division of Infectious Diseases ended off with a talk with an analogy to a James Bond movie. We'd like to present a case that was actually a James Bond movie, frankly. It was full of thrills and spills. There was tremendous excitement and terror, and hopefully the hero won at the end of the day. I'd like to congratulate our young presenter who has shown great interest in the research aspects of medicine. He's preparing this presentation for publication. I think he's put together a fantastic talk for us. Welcome, Dr. Herbst, and you now have the floor.
Thank you very much for the introduction, Prof. And thank you for everybody attending the meeting. My name is Wilhelm Herbst. I'm a registrar in the Department of Internal Medicine. And I'd like to present a talk today titled, When the Right Vaccines Produce the Wrong Antibodies. And as Prof mentioned, quite a James Bond movie. A case of ANCA-Vasculitis following mRNA COVID-19 vaccination in a Jehovah's Witness patient. So the outline of my talk, we'll talk a little bit about the right vaccine. The COVID vaccine in this global context we have now, with then just moving on to the wrong antibodies. So just to give a little bit of an overview to vasculitis in general, and then focusing a bit more on small vessel vasculitides, paying special attention to the ANCA-associated vasculitis. And then we'll discuss the case report, and then also move on to say a little bit about Jehovah's Witnesses and how to approach such patients who have anemia. So from as of the 2nd of March this year, a total of about 31 million COVID vaccines have been administered in South Africa. And the literature has largely proven that these vaccines are both very safe and also effective in preventing death, as well as severe COVID-19 infection requiring ICU admission. And then no drug is benign, so this also has some adverse effects, and most of them should be adverse and very mild and self-limiting, as all of us might have experienced in a personal capacity. And then also in the acute setting, there are some rare adverse events that have been described internationally as well, associated with the COVID vaccine, such as anaphylaxis, vaccine-induced ITP, ANCA-Vasculitis, tendinitis, and myocarditis. And then these are mostly applicable to the acute setting. The adverse events pertaining to the chronic setting and the long-term sequelae is yet to be ascertained. And here's some screenshots from articles that have reported on such rare acute side effects. So here's a schematic illustration from the SAPRA website, a diagram that dates from 17th of May last year to the 4th of February this year, when the vaccine rollout program has started. And it just paints a bit of a picture to show the proportion of all the vaccines that have been administered and how many of these vaccines have suffered adverse events following immunization. As you can see in the middle of the screen, a total of 29 million total cumulative vaccine doses have been administered according to up to this date, and a total of 5,183 incidents of adverse events following immunization have been reported. And this proportionally, this comprises 0.0176% of all the doses administered, which is actually quite minuscule. And of these adverse events, on the right side of the screen, you'll see that 194 deaths were also reported among the people who received the COVID vaccines. 133 of these cases were found to be completely coincidental, 80 of which had COVID-19 disease at the same time, and 3 cases were breakthrough infections. And then also 20 cases were unclassified due to inadequate information. So not really clear that a direct connotation can be made to these deaths as well as the vaccine. And then on the left of the screen, just divide it between the Pfizer and the Janssen vaccine to show that both have revealed some side effects. So according to SAPRA, adverse events following immunization are grouped into 5 different categories, which are firstly vaccine product related reaction. So this is related to the inherent property of the vaccine itself relating to the active ingredient contained in the vaccine. Then secondly, vaccine quality defect related reaction, which is related to quality defects of the vaccine itself or the solution inside or the administration device provided by the manufacturer. And then thirdly, immunization error related reaction, which is based on the inappropriate handling of vaccines, and by that extension is also preventable. Then also immunization, which are anxiety related reaction, where these patients suffer symptoms related to some anxiety like hyperventilation. And then also lastly, coincidental events, where these patients or people who had these vaccines suffered other pathologies which was present coincidentally at the same time, which is of course unrelated to the vaccine itself. So moving on to the wrong antibodies, a bit about vasculitis. As the name says, it is inflammation of the blood vessels, and it affects arteries more than veins. And vasculitis is characterized according to the size of the vessel caliber that's involved. So either small, medium, or large vessel are implicated. And the mechanism by which this takes place is depicted here on the schematic illustration on the right side. It can be either molecular mimicry, which is the case generally in medium and large vessel vasculitis, where the endothelial cells are recognized similar to foreign antigens by the body's immune system, and then targeted directly to destroy them directly, causing direct injury to the endothelial cells and the blood vessels. And then with small vessel vasculitis, usually the mechanism is by indirect injury, where the neutrophils or the white blood cells in close proximity to these endothelial cells are targeted and then subsequently destroyed. The most recent and widely accepted classification of vasculitides is the 2012 International Chapel Hill Consensus Conference classification, and they have subdivided systemic vasculitis into small, medium, large, and variable vessel vasculitis. So under small vessel vasculitis, it's further subdivided into immune complex small vessel vasculitis, as well as ANCA-associated vasculitis. Then these under immune complex vasculitis is anti-glomerular basement membrane disease, cryoglobinemic vasculitis, IgA vasculitis or Henoch-Schönlein and purpura, and hypocomplementaric urticarial vasculitis. Then also the ANCA-associated vasculitis, microscopic polyangiitis, granulomatosis with polyangiitis, formerly known as Wegener's granulomatosis, and also eosinophilic granulomatosis with polyangiitis, also known as Churg-Strauss syndrome. Then under medium vessel vasculitis, subtypes include polyarteritis nodosa, as well as Kawasaki disease, where the coronary arteries are mostly affected. Under large vessel vasculitis, there's Takayasu's arteritis, where branches of the aortic arch is affected, and giant cell arteritis, branches of the carotids. And then also variable vasculitis, variable vessel vasculitis with Behçet's disease and Cogan syndrome. So regarding the pathophysiology, as we've mentioned, endothelial cell destruction is the main mechanism by which these vessels are inflamed and by which the inflammatory process occurs. So it can be either due to molecular mimicry or due to direct destruction, or indirect destruction with the neutrophils that degranulates. With this will eventually lead to the endothelial cell being destroyed, which will expose underlying collagen and tissue fracture. This will cause a coagulation process to ensue, causing clot formation. And this long-standing inflammatory process will then lead to fibrin deposition as the vessel subsequently heals, and then making the vessel less elastic and narrowing the lumen, as you can see on this diagram on the right here, where this is normal blood flow, and then after the inflammation, the vessel will be narrowed significantly, eventually possibly totally occluding it, and then eventually loss of elastin and weakening of the vessel wall, which will then prone this vessel to aneurysmal formation. So here's just a bit more elaborate diagram illustrating the pathophysiological process of ANCA-Vasculitis. So there'll be an exaggerated immune response with cytokines and complement at play, And then in response to these cytokines and complements, the neutrophils will be primed. What that means is that the enzymes inside the neutrophils, such as myeloperoxidase and proteinase 3, will move away from the primary granules in the center of the cell and move to the periphery of the cell, which will then cause them to be in a primed state, which will then allow the ANCAs, the anti-neutrophil cytoplasmic antibodies produced by the B cells, to bind towards these autoantigens on the cell surface. This will then consequently cause cellular activation, which leads to degranulation of the cell, which will then cause the endothelial destruction by release of oxygen-free radicals and proteolytic enzymes. And as this collagen is exposed, the coagulation process will ensue and fibrin deposition will take place, leading to long-standing vessel destruction and an inflammatory process, and eventually necrosis. So regarding the clinical presentation, generally the patients present with non-specific symptoms. So this is related to the inflammatory response. So they'll have fever, maybe loss of weight, fatigability, and then the other symptoms, depending on the type of vasculitis involved, is related largely to the organ that is damaged. And this damage is due to ischemia, as you can see in this simple diagram at the bottom, with the coagulation and the vessel wall thickening, the luminal narrowing. There'll be reduced blood flow, which will lead to organ ischemia. So these patients will present with specific signs pertaining to that specific organ that is that suffers decreased perfusion. So just a bit on small vessel vasculitis. As the name says, it affects the vessels of smaller caliber, so arterioles, capillaries, and venules. And this can be either immune complex mediated or ANCA mediated. So in the case of ANCA mediated vasculitis, these B cells will mistakenly target their antibodies, which will mostly be IgG, as you can see in this diagram here at the bottom, which will be directed against the neutrophils and against their neutrophilic granules, which will then cause them to degranulate. The classification of small vessel vasculitis, ANCAs are the most common cause of new onset glomerulonephritis in adults older than the age of 50. And as per the 2012 Chapel Hill Consensus Conference definition of small vessel vasculitis, it's defined as a necrotizing vasculitis with few or no immune deposits seen predominantly affecting the small vessels. And this will give rise to the classic porcine immune picture seen on histology, which will affect the capillaries, venules, and the arterioles. The ANCA-associated vasculitis is associated with anti-neutrophil cytoplasmic antibodies specific for myeloperoxidase or proteinase 3, which are the proteolytic enzymes found inside the neutrophils. However, there are other granules that can be targeted as well in rarer instances like the cathepsins, elastase, or lysozymes. But generally we test for the myeloperoxidase and proteinase 3. And on the basis of the pathological and clinical features, these ANCA-vasculitides are further subdivided into granulomatosis with polyangiitis, Wegener's granulomatosis, then microscopic polyangiitis, and then also eosinophilic granulomatosis with polyangiitis, known as Scherk-Strauss syndrome, and then also renal limited vasculitis with porcine immune necrotizing glomerulonephritis alone. And then ANCAs can be negative in less than 10% of cases. And this is thought to be ascribed due to other neutrophilic granules being targeted that are not myeloperoxidase or proteinase 3, but rather the cathepsins or elastases or lysozymes. So just a bit about granulomatosis with polyangiitis, or GPA, also known as Wegener's granulomatosis. As you can see on the diagram on the right, these B cells will direct their IgGs to these neutrophils, and then the target will be the cytoplasm of the neutrophil, and specifically the enzyme proteinase 3. And once that has been bound, these cells will degranulate and then release their enzymes and oxygen-free radicals, which will cause endothelial cell destruction by indirect injury, leading to vasculitis. And there will be extravascular granulomatous inflammation, most oftenly involving the respiratory tract in GPA, where the nasopharynx will be affected. Patients can have epistaxis, and on the long term, they develop a saddle nose deformity that's quite classic, and the lungs, where these patients will have significant hemoptysis, as well as the kidneys, where they'll suffer a glomerulonephritis. Treatment for GPA is largely immunosuppression with steroids and cyclophosphamide. However, the RETUX-VAS trial has also shown that rituximab is non-inferior to cyclophosphamide, where 90% remission has been achieved. And with GPA, relapses is quite common, so it's important to monitor these patients closely over the long term, and they also will benefit from long-term immune suppression as well. With microscopic polyangiitis, the concept is largely similar to GPA. However, the main difference is that there's no granuloma formation with microscopic polyangiitis, and the nasopharynx is generally not really affected, predominantly the kidneys and the lungs. And as opposed to C ANCAs, microscopic polyangiitis will manifest with P ANCAs, where these the P ANCAs will be the site, the perinuclear area of the neutrophil will be the site for binding of these ANCAs, and the specific proteolytic enzyme will be myeloperoxidase instead of proteinase 3. And then the same consequence will ensue, where these cells will degranulate and release their free radicals, causing indirect damage to the endothelial cells. Treatment is also similar with steroids and cyclophosphamide. Eosinophilic granulomatosis with polyangiitis, also known as Sjögren-Strauss syndrome. It's with extravascular granulomatous inflammation, as well as blood eosinophilia and asthma. So it can mimic asthma, and these patients can also, the asthmatics are more susceptible to this, and it's also thought to be P-ANCA mediated, and any organ system can be affected, from the kidneys, cardiovascular system, GIT, skin, and the CNS, due to the eosinophilia in the circulation. And this condition is also characterized by granuloma formation. Regarding the etiology of ANCA-associated vasculitis, it's largely not so clear, but multiple factors have been found to play a causative role. There is a genetic predilection, the strongest association observed with major histocompatibility complex, and some studies, genome-wide studies, have found susceptibility loci like the SEPINA1 gene mutation has been identified to play a strong role, and then environmental factors have also been proven to play a big role with silica exposure, and then certain drugs have also been described to cause ANCA-vasculitis, such as hydralazine or certain antibiotics like tetracyclines. Certain illicit drugs like cocaine have also been described. And then mostly we see microbial infections playing an etiological role. These can be bacteria or viruses. Staph aureus have been observed in majority of cases, up to 70%. Other bacteria also include strep pneumonia, Haemophilus influenza, and Klebsiella with H. pylori as well. And then some viruses, Hep C virus especially, and EBV, and then recently also COVID-19. So interestingly, regarding the etiology, there have been reports that have observed temporal relationship between ANCA-vasculitis following vaccination that is RNA-based. Cases have been described following influenza vaccine, rabies vaccine, and now recently also COVID vaccination. And these are also response to all of them are responses to vaccines that are viral RNA-based. And this is thought to be due to the activation of toll-like receptor 7. And then also following treatment with ribonuclease, a significantly suppressed or reduced response has been observed. So it definitely poses a possibility that the response is related directly to the RNA. And here also on the bottom, just a screenshot of a case that has been reported following viral RNA in the influenza vaccine that have contributed to the ANCA-vasculitis following immunization. To make the diagnosis of ANCAs, immunofluorescence staining will be performed. And as you can see on the bottom here on the picture on the left, the stain will react to the cytoplasm, staining that predominantly. which will confirm the presence of C anchors, hence the name C is for cytoplasm. And then on the left or right side, if the stain reacts largely with the perinuclear granules in the nucleus of the cell, it's a perinuclear antineutrophilic cytoplasmic antibody, or P-ANCA. And then the specific targets of the proteolytic enzymes that are involved will be confirmed with ELISA. So moving on to our case report. Our case involves a 77-year-old female of Jehovah's Witness faith with a past medical history of having hypertension and hypothyroidism. She received a first dose of Pfizer mRNA-based vaccination on the 30th of June last year, after which she presented with non-specific symptoms such as malaise, fatigue, and diarrhea. These were mild and self-limiting in character, and medical care was then essentially not sought at the time. So the patient then went for a second vaccination 6 weeks later, after which she then again developed these non-specific symptoms, malaise, fatigue, and diarrhea, this time accompanied by pitting edema, facial swelling, and dyspnea. And this led to the patient being presented to the hospital 2 weeks later. The following blood results were found on presentation. The patient, as you can see, the patient had an anemia with a mildly raised CRP, significant renal dysfunction, likely an acute and a chronic element. However, recent baseline biochemistry was not available. Also, iron deficiency, confirmation of negative COVID PCR to rule out active COVID-19 infection, with serological evidence of P-ANCA being positive, with a high titer of more than 1 to 2,560. Normal is less than 1 to 20, with a positive myeloperoxidase quantified at 62 units per mol. Normal is less than 3.4, and then also negative C anchors with negative proteinase 3 as well. So the diagnosis was then made of myeloperoxidase positive P-ANCA vasculitis with clinical features and serological features suggestive of microscopic polyangiitis. However, histological confirmation will be needed to confirm the diagnosis. So the patient was initiated on immunosuppression with steroids, hydrocortisone at 50 milligrams 8 hourly for 6 days, which was followed by prednisone. Her iron stores were repleted with IV Venofer at a dose of 100 milligrams daily for about 5 days, after which she was further treated with erythropoietin-stimulating agents, Recomon, at a dose of 4,000 units per day. And then the patient was also offered some renal replacement therapy with in the form of low efficiency dialysis. And then plasma exchange was discussed with the patient and then initiated on day 3 and day 4. And then essentially the case was discussed with the patient and the family, and she was agreeable to albumin being used because plasma products were not acceptable at this time. So we had to hold the plasma exchange on day 3 because the hemoglobin had subsequently decreased to 5.7. So this posed a big problem for us because we liaised with Sanbis, and they said that they unfortunately cannot proceed with plasma exchange if the HP is less than 8 due to the increased risk of volume depletion and worsening hyperperfusion to the organs. So it had to be held, and the dialysis by that extension also had to be interrupted. So a big meeting was held with the family, extensively counseling them, involving the family members and the patient, as well as the religious council from the Jehovah's Witness congregation had been counseled and informed and asked to come in for a family meeting to the hospital. The patient's son and daughter had come in, and we explained the situation to them elaborately and told them that it's a bit of a conundrum because we can't proceed with the definitive management of the condition in the presence of such a severe anemia, and correcting that anemia without blood products or will not be very possible. So this was discussed with the patients, and they were well informed of the consequences They, however, still refused to be agreeable to cellular blood products, however, was agreeable to the albumin. So, as mentioned, we spoke to the family extensively and explained to them and told them that if the HB is not improving, we cannot proceed with any definitive management. So then essentially the patient would be for supportive measures and only for palliation, because there's nothing more that we can really do. And they were agreeable to that, and they did accept that, and they were very understanding. So they didn't refuse any other further treatment, only the blood products. So they asked if we can try our very best to see what we can do with what we have. So we agreed and proceeded with pharmacological treatment modalities, where we gave iron supplementation in the form of Venofer, as mentioned, and Recormin, and hoping for the best. And then eventually, to our surprise, the HB had increased to 8.1 on day 14. So this was great news, because it meant that we could resume with our definitive management. So plasma exchange could be reinitiated for another 5 days on day 15 to day 20. The patient then additionally also received 2 cycles of cyclophosphamide with 500 milligrams on day 20 and day 34, respectively. And the plasma exchange was tolerated quite well. And then unfortunately, due to the severe immunosuppression, the patient developed a hospital-acquired pneumonia, but also responded quite well to antibiotics. So then remission was successfully achieved with serological evidence of negative p-ANCA and myeloperoxidase levels. Unfortunately, we could never confirm our suspicion of microscopic polyangiitis due to the lack of a renal biopsy, because the risk was too high of irrevocable blood loss. And this was also discussed extensively with the family, and it was not done. So the patient was then successfully discharged and opted to closely follow up with us as an outpatient, with significant kidney dysfunction still present. She unfortunately did not qualify for the chronic renal replacement program in the South African government sector due to resource constraints. There is strict criteria that patients should fulfill in order to be a candidate, and due to rationing, unfortunately, the patient did not fulfill that criteria. So just a bit about Jehovah's Witnesses and blood products. The Watchtower and Awake, which is the congregation's official biblical journal, they've remarked on the sanctity of blood for the very first time in December 1927, and they released a report in December 1944 stating that a devoted member was forbidden to eat or drink blood, whether by transfusion or by mouth, and which applies to cellular as well as acellular blood constituents. So not just to red blood cells, but also to plasma, granulocytes, platelets, as well as whole blood products. They also said that the fractions of primary blood components, cellular products, and plasma must be conscientiously decided by each individual, and what makes up blood for them in their personal opinion. And by that effect, every patient of Jehovah's Witness faith should be asked individually about their personal understanding and preferences and choices of what essentially represents blood products. And assumptions must not be made that all Jehovah's Witness patients refuse all forms of cellular or acellular blood products. There's also many publications in the literature regarding bloodless surgical techniques like cell-saving modalities. However, these approaches are more applicable to surgical anemias and anemias related to acute trauma or acute blood loss, and is not necessarily relevant to patients who have anemia related to chronicity or due to medical causes. So here's some screenshots from articles that have described such instances, but unfortunately these modalities would not have been applicable to our patient. So here's an interesting study of a congregation in the United States of America in Denver that interviewed every member of the congregation. And they concluded that none of their members would consent to transfusion of blood products, even if their refusal entailed inevitable death. And a third of these participants actually personally have declined blood transfusions since their membership to this congregation. And majority, I think it was 70% of them, stated that they would take legal action against a doctor who would administer blood and blood products to them without their consent. So it's very important to keep this in mind. These patients have very strong beliefs about refusal of blood products. So alternative to blood products in patients who are profoundly anemic include iron replacement, erythropoiesis stimulating agents, both of which have been shown to be very effective over the short term, as we've seen in our case, that have increased the HB quite significantly over a short period of time. And these are also deemed acceptable to majority of Jehovah's Witness patients. Several studies have also explored the outcomes of these patients who decline blood products. As you can see, there's two pictures of articles where TTP have been managed in Jehovah's Witness patients, where of course they could not receive any plasma products or blood products. And also another modality that is available and also registered in South Africa is Hemopure, which is a bovine-derived hemoglobin solution, which is comprised of cell-free polymerized hemoglobin that carries oxygen in the plasma. And it actually enhances the ability of native red blood cells as well to take up and offload oxygen. And the product's oxygen dissociation curve is also shifted to the right, which will then decrease the affinity of the oxygen, of the HB4 oxygen, making them more easy to give up oxygen to the tissues. So this is actually something that can play a big role in such cases. The human HB oxygen affinity relies on adequate levels of 2,3 biphosphoglycerate, as opposed to the bovine hemoglobin solution, where these concentrations are regulated by chloride ions in the plasma. And there was a cohort in Molpark Hospital that included 336 patients, where avoidance of blood products was actually achieved in up to 89% of cases where Hemopure was used. So there's a significant role for this, and it achieves great tissue oxygenation effect rather than necessarily being a red cell substitute. And I included this in the talk because I think it could have been a very valuable treatment option in our patient. However, I don't think it's very readily available, especially in the government sector. So to conclude, this case is not only unique in describing the uncommon occurrence of ANCA-associated vasculitis following COVID-19 vaccine, but also describes an example of adjusting standard treatment measures to accommodate a patient's religious views. Because I'm sure all of us have been faced with this one time or another, but these situations can cause daunting medical and ethical dilemmas, especially when children is involved and pregnant patients. Therefore, it's very important to provide efficacious alternative treatment options in these patients who may refuse conventional regimens due to religious beliefs. And it's very important to have an individualized approach to every single patient to offer care acting in the patient's best interest, and not to prevent or not give any other treatment modalities if one modality is refused. So the take-home message is that vaccines, especially COVID vaccines, they are safe and very effective, and the benefit does outweigh the risk. However, there are complications that can ensue, and it's important to keep them in mind, especially if patients present after having recently been vaccinated. And then also, although Jehovah's Witnesses may refuse transfusion of cellular or acellular blood products, they do accept and also expect the best alternative effective medical care. So not all treatment can be withheld if one modality is refused based on religious grounds. And then also remember that there are many other alternatives to blood products available in South Africa, in the government and the private sector, and very, very important to have an individualized approach to every single patient, especially patients of Jehovah's Witness faith.